well-articulated sector that is doing this amazing work is seeing so many people, is one of the least invested sectors in. How do we, as an NHS, work together so that acute care, mental health services, community services work along with the GP practices in such a way that actually we as residents, we as people who consume those services, we as people who need those clinicians to support us, have care at the point. And there are many terms that people use about how do you make sure prevention happens? How do you make sure people have care at the point where they need it? And one of the terms that is very much in vogue now is about the left shift. It's about recognizing where do you make sure the intervention and support that is delivered happens early enough in the care. And I'll give an example. I mean, I have two long-term conditions. I am a man of a certain age. I refuse to accept my age. I continue to think I will stay on the south side of 50, but I don't. I've crept up to be the north side of 50. Not happy about it, but I'll accept it. So often I have to ring my GP for an appointment, get something checked out. The ability to do that earlier allows me not to go into secondary care services, which would develop with the complications. And that's the crux of our conversation today. Who better then, when you want to talk about the eminence of what a left shift would mean, than the amazing Dr. Johnny Marshall? Many of you know he has already received the King's Award. He has been celebrated for the amazing work he's done. But most importantly, Dr. Marshall has been a GP partner at the West Grove Partnership for over 30 years. So the person we're talking to, the person who's sharing his views today, is not just someone who's worked at national level. He's someone who's rolled his sleeves up and dirtied his hands for the last 30 years, caring for patients in the front line, truly has experience of what we want and what he has had to face on a day-to-day basis. Of course, like many of the amazing leaders who we have seen, Dr. Marshall wears many hats. In addition to doing this work as a partner, he has been the National Director for Policy at the NHS Confederation, which was, I think the title was the Group Director of Policy. And please correct me, Johnny, if I've got it wrong.
That's
But I
good.
mean, yes, you are. So you're celebrated in so many forums that it's not hard to get the information. And he's done some amazing work there before he went on to become the president at the National Association of Primary Care, and now continues to be among the leadership team as one of the execs and supporting this. And he has been instrumental in working towards the left shift in many ways, both at the front line as well as the national policy level to make that difference. Colleagues, I am incredibly grateful that despite being that busy, despite being that incredibly celebrated, Dr. Marshall kindly agreed to come to this webinar and help us understand his view, his perspective of the left shift. But just before I hand over to him, a reminder to colleagues, we have over 200 people registered on today's webinar. So pardon me, it would be really hard for me to take everyone's question. I'd love to, but we'd probably be here till tomorrow morning, and many of you may just want to have a little 7-hour sleep there. So what we will do is if you post your questions in the Q&A tab of the Zoom app, I will ensure I pull out the themes of that and share it with Dr. Marshall for his views. For those of you who have been kind enough to already send your questions through, please be assured I will pick them up as I go through today. Johnny, it's an absolute pleasure having you over. Shall I hand over to you now?
Thank you, Mo. That's for your very generous introduction. I think the work you're doing is truly inspiring, and it's a privilege to be here this evening. Thank you all for tuning in. I hope that over the course of the session that hopefully I'll give you something to think about. Maybe there's some things that you're going to disagree with. Well, yeah, let's hear about those. Maybe there's some things you're hearing for the first time. But you're the guys that are leading change, the teams that are leading change at our local level. So So you understand the needs of your populations, and hopefully something that from this evening will just give you a little bit of insight and new impetus, that you might be able to go and continue to make great change at a frontline level. So this sense of left shift, and when I was looking at the LinkedIn posts ahead of the webinar, I could see there was a question that Moet very gently rebuffed to make sure people signed in to hear about a left shift today. So what does a left shift mean? I think this sort of sense of how do we move from an acute reactive healthcare where we're rescuing people and being reactive to something that's more proactive, more preventative. It results in lower costs, it results in better experience, it brings more joy and meaning to the workforce, and all in all, it represents much better value to, I guess, ultimately to the taxpayer. So this left shift or moving upstream, how do we become more proactive, more preventative? I guess for me, that's what it means. And it would be fair to say over those 30 years in general practice, people have been talking about left shift, getting upstream, being more preventative for a lot of that time. And yet we still find ourselves talking about it. We still find ourselves regarding it as being really important. And when you look at the projection of the percentage spend of GDP on the NHS over the next 50 years, going up from the current 8.5% to 15%, 15%. You realize unless something fundamentally changes in the next 50 years, we're crashing into a completely unaffordable healthcare system. And therefore, maybe the future of the NHS actually does rely on getting this right. So this evening, I guess I'm going to be talking about how we do this left shift and how we get it right. Questioning why maybe it's not been effective so far, what we might need to do differently if we're going to be successful in the future, and unpack how we might look at that potential benefit. So let me just start setting just a few sort of, I guess, ground rules and parameters. So on the next slide, I've got a definition of health and well-being. So when I'm talking about health and well-being, I'm talking about these things. It's not the Johnny Marshall definition of health and well-being. It's not even the NAPC definition of health and well-being. It's not even the NHS definition of health and well-being. This is the World Health Organization, and you can see the richness and the roundness and the connection to happiness, satisfaction, how you feel about yourself, how you feel about life. Isn't this what we all individually want? And isn't this what the communities that we serve also want? So when I'm talking about health and well-being, this is what I'm talking about. On the next slide, I've got a definition of primary care. We are the National Association of Primary Care. And as a GP, I have to admit, there is more to primary care than GPs, okay? So here we have, again, the World Health Organization of Primary Care, and you can see this functional description. Absolutely, it's reflected in the core of high quality general practice. But you'll also recognize it applies to community services. It applies to voluntary services. It applies to social services. It applies to the community itself. This is the true definition of primary care. And we know that if you invest £1 in any of these things, £1 into primary care, you get a £14 return to the value of the economy. This is not just how you might reduce demands on the NHS. This is a return to the economy, people being at work, people being happier, all that sort of stuff. And if you think, well, maybe that's just true in England, in the UK, well, in America, if you invest $1 in this, you get a $13 return. Pretty similar figures, okay? So the function of primary care, this functional description is what the National Association of Primary Care is all about. And this is what I'm going to be using when I talk about primary care. And when we're talking about neighborhood care and neighborhood teams, this is what they're made up of in terms of those primary care functions. The next slide is slightly humbling for those of us that work in healthcare, because there's a lived reality that our communities, our residents live, that only about 10%, maybe 15% at a stretch of a population's health and well-being is linked to access to healthcare. So that means the greatest influences on people's health and well-being come from somewhere else. And lifestyle, how you eat, sleep, move, connect, makes up about 40%. Some of the other things you'll recognize: poverty, having a job, housing, family, friends, etc., etc. And so Michael Marmot, who is clearly a very eminent a man in this area, has issued this sort of, I guess, this sort of challenge, and maybe a bit of a professional responsibility for us. Are we simply treating people and sending them back to the conditions that make them sick? And although it may not be our professional accountability to resolve those particular situations, calling it out, understanding the importance of it, and that by getting those conditions right, the wider determinants of health, people are less sick and therefore less demanding of acute services, including ours, we have a vested interest, not only in keeping them well, but ensuring that they have that wider sense of health that keeps them away from requiring our support. The final thing on the next slide is a really important truth that often gets overlooked. There's a sense of person, agency, or activation. It depends what language you use, but essentially there are 4 different levels. And at level 1, essentially we have people feeling, you're the doctor, you tell me. At level 4, we have people who are advocates for their own health. And when you look at the UK population, we're divided about 25% across each of these 4 groups. The key is, if you can enable people to overcome their personal barriers to this activation, you make a huge difference. You make a huge difference, not just their sense of health and well-being, as we've just described, but you make a huge difference on their demands for healthcare services, including GP appointments, primary care appointments, dropping 18% if you move from level 1 to level 4. And this was all costed on the basis of 2021 prices. And if you can move people from a level 1 to a level 4 activation, you will release £1,670 per year through a reduction in all of those acute services that you can see on the slide, not even taking into account all those other benefits in the box just across it. And when you're trying to contain your GDP at 8.5% with a 15% target just 50 years down the line, you need all the help you can get. So how we tap into the power of our communities, our residents, is going to be critically important in meeting the challenge. So what's all this got to do with the left shift? Right. Are you sitting comfortably? Just now I'll begin. The next slide shows, I guess, a typical pyramid. And you've probably seen these pyramids, like this one that Harry's about to pop on the screen, that look at how we are sort of consuming healthcare resources. And this is one from Martin Rowland, another esteemed general practitioner, looking at emergency missions. Yeah. And on these pyramids, you can always see the very high risk, intense users. And what we tend to do is we tend to focus on those and the case management. And if we can just stop the most frail, older, high-risk people being admitted to hospital, we can free up lots of resources, shift everything left, get upstream, and hey presto, resolve the financial challenges within the NHS. This sort of case management approach. You'll all be very familiar with that and very familiar with a pyramid. But within this pyramid is another story. And as you walk your way down that pyramid, you can see that the majority of people that end up in hospital with emergency admissions are not from the very most intensive high risk. They're from the lowest risk. Yep. And it's really important that we start to recognize it. You don't melt an iceberg by shining a very bright light on the top of it. You melt an iceberg, as we are currently learning to our cost, by warming up the water. If we are serious about shifting resources away from a reactive acute center focus. We have to warm up the water. Not focusing on the very top, case management, not that that isn't important. It has a contribution to make, and for the individual people, it can make a difference. But there are some flaws with relying totally on that approach. The first is that actually there's a sense of regression to the mean. This group of people who have been coming in and out of hospital for a couple of years, 2 years, maybe 3 years, then they stop because they regress to the mean. So focusing all our energy on them when they were probably going to drop out of that group in the first place, or certainly a third was, means we don't get the return that we required. Second is that actually assuming that people not being in hospital is good for them isn't always correct. There are some people that absolutely need to be in hospital. And if you don't get them in there, you've done them a disservice and probably cost yourself even more in the long run. The fourth is that there is a sense in which there's a supply-induced demand. And simply having the beds draws people into hospital. It's nobody's fault. It's just the clinical stewardship and the behaviours that sit behind it. And a final one, that there are others, and if you want to read them, then Martin Rowland's paper is excellent. Is there's just a lot of variation due to chance. So you go chasing sort of a case of management, 9.3% of total emergency admissions, more than one admission per person on average, yeah, and you never realize the benefit. So we put a lot of effort into this left shift, and 30 years later, we're doing the same. Well, what about if we took a different approach? So this is the case that I'm wanting to make about, instead of having this case management approach, what about if we took a population approach? And to do that, we need to flip things onto their side. So on the next slide, you'll recognize a normal distribution curve. I'm sure many people have seen one of those, okay? This is how the population sits. Some people are very well, and some people are very poorly, and most people are somewhere in the middle, okay? And this slide shows what happens if you take that case management approach. Okay, so that green arrow is all the things we could do to take the sickest, most vulnerable, frail people in a hospital and push them back towards the community in a very positive sense by putting in the necessary preventative, proactive approaches. And you can see you gain a little bit of benefit as that red curve brings you in, and that blue that's showing is now where you've saved the cost. But you're crashing that red into the rest of the blue. Those services that sit on that threshold in primary care are now having to deal with the capacity of the preventative and proactive, but still all of the other demand that sits to the left. So Geoffrey Rose, an esteemed epidemiologist, and this initial piece of work was around hypertension, I believe. So you can imagine we've got strokes and cardiovascular events on the right-hand side, all the way through to people who are walking around healthily with healthy lifestyles on the left-hand side. He argues what's on the following slide. And the next slide shows you what happens if you take a population health perspective. So rather than just focusing on that escalation of care and seeing if we can shift that left, what about if we think about people who have chronic diseases? How do we enable them? And I was looking at some work the other day just to give you some examples about what I mean by this. There are 4 PCNs working with a company. I won't name them because there are lots of companies that do this, providing digital health coaching around people that are newly diagnosed with diagnosis or non-diabetic hypoglycemia. What they were demonstrating is through a little bit of personal contact, but mainly digital health coaching, they could reverse people's type 2 diabetes in 38% of the people who attended the course. So we've gone from managing diabetes to reversing diabetes. We've shifted the curve from the blue to the red. So once we get to halfway, we're now looking at prevention. How do we increase prevention? And there are some great examples of community health and wellbeing workers who are currently working, I think it's at about 10 areas within England, and NAPC has been supporting that movement. There's lots of information on it on our website. You will have heard, you might have heard Wes Streeting talking about it, starting to gain political attention. So in the most disadvantaged communities, community health wellbeing workers who've grown up and living in those communities are going around knocking on doors, visiting families. Yeah. And they're engaging with families, and they have a real endeavor to wish to improve the health of their community, and they'll come back and knock on your door until you open it. And they're building trust, they're building relationships, they're understanding what's important to people, and they're getting into those wider determinants of health I was talking about at the beginning. By addressing what's really important to people, some of their financial issues, some of their housing issues, they're starting to get people's trust. And we're seeing an increase in people attending for cervical screening, an increase in children attending for immunizations, a reduction in people coming to see the GP, all because we have activated people probably from level 1 just to level 2, and it's having a massive knock-on effect. So we're shifting the curve left because now people are engaging in prevention because we are focusing on what matters to them. And then the final part is that sense of creating health. I almost caught you out then, Harry. So the final part is about then creating health. Now, I'm not going to be as a clinician. Oh, well, maybe I will when I reinvent myself. But it's probably not my primary responsibility to be running a community kitchen that is teaching people how to cook healthy, really tasty, inexpensive food to create health. One of those determinants of health of health from the outset. But it is important that I know about it. It is important that I know it's in my community. It is important that I'm speaking about it. I'm encouraging people to participate because there are thousands of community-led initiatives, whether it's walking, whether it's chatting over knitting, whether it's men in sheds. You'll have heard of them all. Yeah. These are the ones that are creating health and shifting that curve left, addressing mental health issues, loneliness. This is what makes a huge difference. So my argument is we mustn't just focus on the case management and how we prevent that escalation of care, however important that is, and however much it matters to people. It's not we shouldn't do it, but if we do it to the exclusion of the others, we miss out on the opportunity to shift the whole population health left. And some people say, well, Johnny, this is going to take a long time. Yeah. And really, we've really got to get on with getting more productive because you just told us that in 50 years, we're going to hit this 15% of GDP. And I asked ChatGPT just to calculate what level of productivity would be necessary not to hit 15% in 50 years to keep us at 8.5. And the answer is 75.6, roughly, percent. Okay. So the typical NHS way of thinking about this is saying, well, look, we'll just make 1 or 2% a year. We'll just keep shaving it off. And you multiply that by 50. Johnny, we'll hit 75%. It'll all be fine. I'm going, you're back into case management mode. Okay. What we need to think about is the children that are being born today, who in 50 years will be demanding of healthcare services. How do we reduce the number of those that need long-term condition management? How do we increase the number of those that are contributing to prevention and being picked up early? How do we improve the wider determinants of health around that group? Because that's the group that's going to be costing us money in 50 years' time. So my case is that we have to look at the whole population. You cannot afford not to do this. It may not be our responsibility in our professional roles in primary care to do all of this, but we need to understand the benefit of it, and we need to be championing it, even if it's not something that's our day-to-day responsibility. And I'd be really interested to hear what people think about that. Thank you.
Fascinating. Absolutely fascinating. Harry, would you take the slide down so we can see the speaker? I think, Johnny, when you was talking, there's this thing around the hair on your hand standing up, because that's how motivated I was to think. So there is a real possibility of making a true difference so that we have a lasting legacy on the health of the people. And I'm absolutely sold on the fact that if the ownership of health has to lie with the person who has the health rather than the health service, which is where we've come to. It's such a dependency-based model rather than a model that actually supports people to say your ownership. And there are loads of questions, as you can imagine, that are already shooting up. The very first question came out by slide 2 of yours, by the way. I was measuring, so that's a new record you've set. Slide 2, it's never happened before, but it was out. So let me just start with the first question that I'll answer right away. So there's a colleague who's asked about these slides being shared with them. Colleagues, we put out the recording of the whole webinar. It's available for anyone to see, so you'll see the slides there too. So it doesn't need to be email. Please just go to the YouTube platform and you'll find the films there, and we keep it there so that people can have a look at it, even the old webinars if you want to see. So let's go to the first one. It's a really interesting question, and clearly it is phrased in a way that I don't think I agree with. So I'm going to ask it the way it should make more sense to people. The current primary care model, and when I talk of primary care, I'm talking of GP practice alone, not the width of primary care, which is truly primary care, is so fundamentally entrenched in what a GP practice contract requires you to do, rather than rethinking fundamentally what happens as a doctor, what would you be involved in doing? And I mean, I was trained like you, Johnny. I mean, I qualified almost 35 years ago, now 33 and a bit. So you didn't have you didn't have a contract for consultants. You didn't have a contract for doctors. Actually, there was an expectation of what you were doing wasn't the right thing. Sometimes I can understand the logic of trying to get a contract to truly understand what the currency of activity was. But the challenge in that is it has also broken down the fact that people did what was the right thing to people doing what the contract requires to do. And there's a lot of conversation on will the contract stay? Will it change? Will West Streeting have a view? And every health minister who comes in has a view and they change. But what they change is always needed by the communities. And that's what we're here for at the end of the day. How do you think does that interplay between the left shift, which is phenomenally important as primary care to be leading on, play with the current contract, and how do you think can that there be some alignment there?
This is we had a dinner with Sir John Oldham yesterday from an NAPC perspective. One of the things that the people around the table were talking about is this real need to align national priorities and contracts with what you're asking people to do on the ground locally. Because if you don't do that, you're just making it really, really hard. So I absolutely buy into the fact that's a really important enabler. And there is going to be an opportunity to look at that GP contract over the next 3 years, but that's quite a long time. So what can we do about it in the meantime? I think that the trick lies in identifying those elements which are not only good for people in their experience and their health, but also results in people being less demanding of our GP services. So that by investing time in supporting them in this way, clearly there will be a little bit of a cost to do that initially. But as the requirement for GP services starts to fall and the pressure comes off, we'll start to see the benefit of that, even within the restricted contracts. I was watching one of your previous webinars with Paul Vaughan, who was talking about the care program, which he commissioned from NAPC, where we have had initially general practice nurses, but as the program developed, it broadened out to other primary care professionals who are looking at maybe the half an hour a week they might have had and how they can invest that to make a difference. And time after time, what they showed is that if they just asked people what mattered to them and engaged in that conversation, they were seeing reduction in the number of GP appointments in the following year by about 4 or 5 per year. So I think it has to work for those of us working in clinical practice. It has to take some of that pressure off and some of the stress off, because joy and meaning at work is a fantastic thing. And finding that thing that really don't feel embarrassed about that. Don't feel that in some way you're being selfish about that. It's great for patient experience. It's great for patient care. It's great for safety. And finding those things where you have an amount of time you can invest and looking at to invest it in something like this, you will find a return the next year in the pressure that it demands of your services at the very least. Sometimes there will be a local initiative or a local investment, although maybe not so much investment at the moment, that you can tap into. And I guess I should really promote NAPC at this point. We're very much a sort of a community of practice, looking for people who are really interested in making a difference and sharing that learning between them, so they can see what other people are doing and think, oh yeah, that might work for me if I tweak it or take it on board, so that you can find these little nuggets that really align around everyone's potential benefit despite the restrictions of the contract.
Fascinating. And I completely agree with what you're saying. I think the work you're doing now and trying to align what the contract is from what it should do is so important because it sends the wrong message. People think differently. Let me just change tack to slightly something different. 35 years ago, I came out as a doctor, bright-eyed, bushy-tailed, wanting to change the world. I would do everything and the world would be a better place. I was trained in a certain way. It was a different world, the expectations were different, and I was trained correctly for those times, but the world's moved on. The expectations have moved on. I don't recall this level of obesity-related diseases as exists now in the world. It's a different world, different lifestyles, different conditions that affect us. Stress is there, which impacts in so many ways people don't realize that it is phenomenal. The issue, though, with all the conversation around the right thing to do on the left shift and the focusing on doctors to do the right thing, clinicians to do the right thing, it's fascinating that my daughter, who is now in medical school, is studying exactly the way I studied, with absolutely no difference. Okay, it's the same training I have received, is same, and I sit back and think, but the needs of the communities are different. The expectations are different, and we are increasing. I mean, I love the term you spoke about, agency, activating people. I love it. I think that's the right thing. Why should a diabetic ask me for a solution? I would rather they came with saying, I've read all this on the internet. This is what I've done. Why would you not prescribe this? And that's a very engaging conversation to have. How do we change that? The training of our clinicians so that they are actually in tune and understand. Because until we change our behaviors and the way we operate, we do create an element of dependency, which is really hard for then our patients to step back on because they are respecting us by just stepping back and saying, right, you lead the path.
I think the fact there are 200 plus people listening to this webinar means that that personal responsibility around being curious is where all of this starts. If you have a sense of certainty, you know how everything works, you know how everything's done, and you're not curious about how things could be better, that's a really difficult thing to change. So I think we all have that sort of professional, personal responsibility to be curious. Is there a better way of doing this? No need to be ashamed that it's good for us as professionals as well as it is for the residents, the people, the citizens that we serve. But if you can get them aligned, that's really powerful. I recognize your journey of coming out thinking I could solve the world, and within about, I don't know, maybe it was 20 minutes, realizing that wasn't going to be the case. And I think I've been wrestling that with through all of my career, and my understanding of this has grown over that period of time. I think that this is going to be really challenging to change that at a university training medical student level right now. And we're even struggling to change the NHS healthy eating guidelines, which are still out of date. They're still talking about low-fat foods. They're not talking about all of the understanding that we have about eating real food, basically. Yeah, so it's a real challenge, but that doesn't mean that we can't take that challenge on ourselves. Yeah, so that the way you describe that changing of disease, this sense of metabolic health, is a really interesting evolving landscape. We were initially recently asked to contribute to a piece of work NHS England was doing about how you manage people with multimorbidity. Yeah, so essentially, I guess, grouping people together in a cloth type clinic. And we said, well, look, rather than taking a disease perspective, why don't you take a cause perspective? So when you look at people who have diabetes, hypertension, cardiovascular disease, strokes, probably mental health, yeah, maybe musculoskeletal disease, some GI diseases, actually the common trigger is their metabolic health. Weight isn't the problem, weight is a symptom of poor metabolic health. And if you, and I guess this is where that digital coaching comes in, if you get people, support them around how they eat, sleep, move, connect, physiologically, you see a reduction in inflammation throughout all of their body. And symptomatically, you see almost every single long-term condition improve. So if you're really curious about how we tackle this epidemic of new long-term conditions, then curious about metabolic health, taking you into the causes. So we're back into the wider determinants of eat, sleep, move, connect is really important. And I think the power that I will speak specifically about GPs right now, because there is something very special about that relationship and the way they are regarded in society, which comes with a huge responsibility. If GPs are sticking to a biomedical model, and there's nothing wrong with that for certain aspects, but if they're not extending it into the psychosocial model, then what we're doing is we're reinforcing the dependent culture that you were talking about. If we start to encourage people actually about activating, managing their own long-term conditions, bearing in mind if you took a page of A4 and you put 100 dots on them, where blue represented the amount of time people spent managing their own conditions and red represented the amount of time they were connected to healthcare, they'd be 98 and a half dots that were blue, and there'll be one red one and a little smidge down in the bottom right-hand corner. If you're recognizing that and enabling people and to overcome the barriers to do that, that's incredibly powerful. And it might only take you 30 seconds in a very brief intervention. So I think that's the challenge. It starts with our own personal curiosity, then digging deeper into some of these wider terms of health that have such a bigger impact. But ultimately, it will require us to skill people up differently from the outset so they really understand this.
You remind me of a story. Ages ago, I remember I was sitting in a room with a mother who had a child who was neurodivergent, and she was asked, who is the professional who you most often use? And first, the professionals were asked in that room, who do you think it was? So the GP stood up to say, me. And I remember the consultant standing up and saying, oh, learning disabilities, it's me more often, will not be the GP as often because it's more complex. And as age increases, we know that there are certain conditions that they're more preponderant to. And then the mother stood up and said, actually, no, the person who I'm most dependent on is the bus driver because he
There
makes
you go.
sure my child goes to a park every day. Every day he's made friends with him and tells him which park to go to. Because of that, I'm able to get on with my life because my child's become independent. He loves exploring. And you sit back and think, our ability to do that biosocial model that you're talking of is so crucial that we don't get caught in the medicalized model where we are there. I think, as you would expect, Johnny, with things like this, there are loads of questions about money, money, money. Okay, rightful question. We are people of the world, and that's where the life is. And there are questions from one end of the spectrum to, do you not need money to pump prime this and start something like this? To the other end of the spectrum, saying, actually, so if you release that money, why is that money not moving then from the secondary tertiary services into primary care? And when they're talking primary care, no one in the question is actually saying GP practice. So they're saying primary care, which they are right, because actually if one looks at the services that are most often denuded in the community, it's the voluntary and community sector, which you need more than anything else to make sure people stay connected. So, from the work you've already been doing, and NAPCB is doing some phenomenal work. Hats off to what you all have done, I have to say. Every time I read about it, I go back awestruck. What have you seen around that, the monetary movement? And have you seen anything around the reinvestment models into supporting primary care and preventive models?
Yeah, that is such a good question and such an important enabler. And as we're about to set on a course of encouraging people to develop new care models around neighborhood care, which will include some of the things I'm describing, and yeah, we haven't worked out how to invest in them properly. The whole thing could fall over at that very point. And this is when we know that every pound is going to deliver a £14 return. From a governance perspective, they're going to get it all back. And if I offered you a £1 for £14 investment, I guess most people on this room, well, they might have spot the catches. Once they worked out there wasn't one, they'd sign up. I mean, this is really challenging, and I think part of it comes from building an evidence base to win people over with the argument. Now, we have been working on that from an NAPC perspective in the integrated care systems that we have been working with, that demonstrates the value of investing in activating staff in the first instance. Yeah, if you just invest in activating people, you get a 7% improvement in productivity like that. Okay, happy stuff. So there's some really important things you can invest in and get really quickly. If you then get them working alongside other people who coordinate care, they find where all the gaps are. They cut out all of the waste, they make things leaner, and they get another significant improvement in productivity. Now, none of that really releases any money because you're just taking the heat off delivering the service, but that makes us all feel an awful lot better. And there's always a balance, isn't there, between money, work-life balance, stress. So it's part of that balance. When you then take that into activating people, that's when you start to see real savings in the way that I was illustrating, that allows you really then to start reinvesting. Yeah, and activating communities, the final step. You get a whole level of real money that you can move around the system. So there is a sense in which, in the current situation that we have, there isn't really a mechanism to do that. But we are working with members, with systems to try and produce the evidence to convince the sort of the policymakers that you need to address this if you're really serious about making neighborhood health and this approach business as usual. And you need to, because you've got a 15% GDP staring you down the line. So I absolutely recognize that the challenge at the moment. I guess what we've probably found is that people have worked out, look, I've got 10 minutes this month to do something. And if you invest that 10 minutes, you'll probably see a return. Finding money is going to have to come. I obviously just agreed the new chiefy contract. We're not sure there's going to be any money. We're not sure there's going to be ICBs to allocate the money, but being part of that voice is saying we need to sort this out. Certainly that's something that we have heard loud and clear, and we are representing to policymakers. But we need to produce the evidence collectively to demonstrate that we can make this stick and allow that disinvestment from other services to take place.
And I think I do agree with you completely that sometimes it's not the money investment alone. It's also recognizing that cuts in primary care are less than elsewhere in the health service right now. So most of the health service is going through a 7 to 8% cut right now. That is the extent of financial recovery that's going on. Primary care has got additional investment. And don't get me wrong, there is no such thing as a free lunch. So I'm not going to sit down and say that means people will just be sitting and they've got more money. There's a lot of work happening in primary care. And I start this webinar always with the statistics because I want people to remember it's an amazing sector where the return for investment is great. But we have to
Phenomenal.
recognize. Exactly. And I think it's brilliant what happens in primary care. But the very fact that there has been additional investment in primary care rather than the cuts that are elsewhere in the health sector does show the recognition. People like the health minister who is treating, people like the Department of Health, people like from NHSE haven't. I have been in meetings with our new chief exec from the NHS England, and I have always heard him speak very highly of primary care, very highly. And both the meetings he spoke how eloquently how investment to primary care actually gives better returns than most other parts. And what was really good and heartening to hear when you said there are times when you have to get people the right care, which is not the lowest level of care. But actually, if you move things to the left shift, you also have resources freed up to give people care earlier in the pathway rather than having to give everyone the same pathway much later. And I think that was a message that stuck in me. I think the question, though, that comes in is you spoke about activation, and I think activation is brilliant. But when you are activating someone like me, it is just a tad late. Much as I refuse to accept this with my daughters that I am, it's a tad late. But if it is done much earlier in life, when kids are young, their habits and behaviors are forming, they recognize healthy eating, exercise, keeping themselves fit, reading well, talking well, not getting stuck on that silly phone the whole time where you can see TikTok and stuff like that. How do you think we could approach that? Because often I find, and it was such a brilliant example you gave just 10 minutes ago when you said, if you've got 10 minutes, use those 10 minutes to do something different. Don't bother about anything. And to me, what struck was, if you've got 10 minutes, just go to your local school and talk to them about good food, talk to them about going out play. And I just wanted to ask you, is there any conversation happening nationally in terms of policy making to rethink how do we start activating those young minds from now so that we are in a better place in the next 15 years rather than continuously working with people who are of my age who do change, but it's a tad later than we would have liked it to be?
It's virtually never too late. So an aging older person who has been fairly inactive and they're walking to the cliff at the end of their life, if they start being active, 70, 75, whatever, they slow down the journey to the end of that cliff. Okay. It's never too late from a sort of perspective of eat, sleep, move, connect. Lonely people who I may have seen people in my career who presented looking seemingly depressed, you know, who I probably gave them fantastic um, um, chat and encouragement and referred them for counselling and maybe even used some antidepressants because there was probably a checklist for that as well. And turned out they were lonely. And if only they'd gone to the Knit and Natter Club down the road, they would have felt just as well. It's never too late. Okay, so it's never too late for these things to have an impact. But obviously, the earlier you can introduce them, the better. And childhood obesity is one really good example where we know that if you implement things early, you make a massive difference. It's much easier to do it at that point. So I guess that's my point about we need to start with the zeros to make sure when they hit 50, we've got our GDP under control. I think from a professional perspective, if you're curious, even if it's the last person you ever see in your career, and you just do something different, whether it's just to ask them what matters to them, and you might activate them just by doing that by one level, you'll have an impact even at that point. So it's never too late. It's never too late. It's just, I guess, with all of that sort of the pressure people are under, that burning platform, it is really hard to find the time and the space to do that. But if you find a little gap, then in the knowledge that it will make a difference, it's never too late. You're making a difference, and I guess that was the beauty about general practice, isn't it? Every 10 or maybe it's 12, or if you're really lucky, 15 minutes, you get to make a difference. Um, uh, and you can do it in less than 30 seconds. We know that from smoking, brief interventions around smoking. We know it also applies across all of those things. So it's never too late. Have I said that enough times yet?
I think it is going to be my mantra. I'm going to tell my wife every time she tells me off for something. It's never too late. I still have time. Don't worry about it. But you're spot on. You are spot on. And I think that's what's fascinating about healthcare. People often assume it's too far gone down the lane of not being able to make a difference. But actually, there is so many things one can do to keep fit and to stay healthy that can make a difference to the outcome, irrespective of the age. And it might still be different for different people, but it'll definitely be better than it would have expected to be. And at the end of the day, we all know, I mean, what's fascinating about life is death is an inevitable outcome for everyone. There's no one I've known who's lived forever. But being healthy, not being dependent, having that control on yourself, enjoying life. And I love the definitions of WHO that you rattled through when you're talking about health. That is so true. It is the happiness that you're looking for. It's the social connections, the value that you derive from life that you're really looking for. Johnny, I think I've got tons of more questions still there on my page that people have posted. But unfortunately, time's always the enemy in these webinars because we have to come to an end. And colleagues, many of the GPs who are online, I know you've been having a long day and you've very kindly still stayed on. If 200 of you have registered, you know exactly what you've been trying to do. So I don't want to keep you beyond 8. And I just wanted to start by saying, Johnny, today, the concept of left shift, I have read so many things about the left shift in so many publications. It was absolutely brilliant to see how you brought it to life. It was really interesting, and there's so many things that struck with me today. I hadn't read about this 8.5% GDP changing to 15% if we did nothing in the next few years. That is shocking statistics, because actually what we're talking about, colleagues, is if we don't change it, our kids and grandkids will have so much of tax to pay to keep the system going that the benefit we have derived from the NHS would soon disappear if we don't do something dramatically different, which is all we are talking about, is owning our health. I love the statistic about £1, £14, $1, $13. Listen, we bet the Americans even in that, but what am I going to say? I think there is something around recognizing that if you had examples where 38% of people actually reversed their diabetes, my God, that was startling statistics. And colleagues, we're talking about changing your life forever, from a person who can't have a sweet, from a person who can't enjoy any of those things, from a person who most likely is going to have some cardiovascular impact, some renal impact, some vascular eye impact. None of those happening. What we're talking about is reversing diabetes, not managing or controlling it, which is what we used to talk about. That's phenomenal statistics. So you can make such a difference to the population and the lives of people and reduce the cost. That was amazing. I absolutely love the bit about activating the power of our communities and people. And that's something I've always believed in. And even when Sir Sam was here and talking about prevention and how to, it was what fascinated me. It is the power of that that makes a difference to how healthcare is provided, because ownership from people is going to make a difference. And I loved it. I'm sure with the 200 odd people who registered and are on different platforms today, many of them would have taken back much more and probably thought of me, why the hell are you picking up those 4 points? We've got four other points which are better, because it was such an action-packed one. So a big thank you to you for this, Johnny. I'm so grateful you found the time to come and give us this time. I
It's
think
been a pleasure and a privilege. We will be posting on LinkedIn through NAPC after this. So genuinely, if anyone wants a question, find our next post, grab on it, join us, ask the question, and I'll do my very best to answer it.
fabulous. And colleagues, this may appear all very nice and smooth and well run, but it wouldn't happen but for people like Fran and Harry in the background, who just make this appear so beautifully slick. I don't know how they do it. I'm of an age when digital stuff flies by me, and they make it appear so beautiful. And they've got different platforms. I'm on different active live chat happening. I don't know what all this is, but I do know, but for them, I couldn't have done this. So a big thank you to Harry and Fran. Colleagues, all this effort I put in, all this effort our speakers put in, is only because so many of you show love towards this and attend this and give your time. It wouldn't happen. So thank you so much. Dr. Marshall today spoke very actively about the power of activating people, how you give them that digital power and they are reversing diabetes. Our speaker next month is Marta Fisher, who has been leading exactly that piece of work in the Oxfordshire ICB area. So we are looking forward to hearing from her. You would see on your screens that you have two QR codes. One of them is for your feedback. Please do take a moment to give your feedback, because it is vitally important for us to make sure we are in tune with what you would like to hear from us. Also use the second QR code if you would like to register for the next webinar. I'm excitedly looking forward to it. And before I close, once again, Johnny, it's been an absolute pleasure having you. Thank you again for your time.